And good morning, everyone. Welcome in. Brand new edition of Sports Medicine Weekly on this Saturday morning. I'm Steve Cascio, joined by my usual co-host. He is Dr. Brian Cole, head team physician for the Chicago Bulls, one of the team physicians for the Chicago White Sox, sports medicine specialist, orthopedic surgeon from Midwest Orthopaedics at Rush. Our website is sportsmedicineweekly.com. How are you, Dr. Cole?
Doing great this morning, Steve. Good to see you.
Good. We're going to lead it off with a great guest and, an interesting topic, NFL hip injuries. And our first guest, Dr. Shane Nho, one of your cohorts at sports medicine surgeon from Midwest Orthopaedics at Rush. And he is his practice focused on sports medicine and arthroscopic treatment of the hip, shoulder, and the knee. He's also the director of the Hip Preservation Center at Rush University Medical Center. And we thought we'd get into a little bit about the Alabama quarterback injury, right? That's probably the biggest injury in college football this year. Alabama's quarterback, Tua Tagovailoa. And, that was, what are we calling it, a fracture?
Well, so it's an awful injury on many levels. You know, where the time it happened in the game, there's when you look at this injury, there are questions about, should he have been playing, and that's armchair quarterbacking. And then there are issues pertaining to how rare an injury like this actually is. These are things that we see, what we call a posterior hip fracture dislocation, and we'll let Shane explain it. But these are things we typically see in motor vehicle accidents. When someone is going to rear end something or a stationary object at a very high speed, they put their foot out, extended, and hip flexed, and the hip gets dislocated, comes out of the socket and goes out the back. It's an awful, awful injury. So it's extraordinarily rare. And then there are the issues pertaining to what's going to happen going forward, because these have sometimes a very precarious natural history in terms of what might or could happen downstream. Main question being, will this athlete ever get back to play? And if he does, what's the predictability of it? So it has a lot of really important topics embedded in it. So I'm glad we have Shane on this morning to help us walk through this.
Okay, so Dr. Shane Nho, MOR, thanks so much for being with us here and leading us off on Sports Medicine Weekly. Can you kind of take us through what a fracture dislocation of the hip is?
Sure. So, thanks, Steve and Brian, for having me on this morning. This is a very interesting and timely topic, given the significance of the injury and obviously the significance of the player as well as a future top draft pick for the upcoming NFL. But as Brian alluded to, hip dislocations are extremely, extremely rare. They don't happen very commonly. It's not like a shoulder. The hip is inherently stable. Just to kind of bring the audience up to speed, the hip is a ball and socket joint, but the ball and socket is much more constrained than the shoulder, and so it's not very common that a native hip would dislocate. And in general, it takes high energy injuries for these to dislocate. So as Brian alluded to, the most common scenario that we see dislocations are from like dashboard injuries from a motor vehicle accident. Car is going at high speed. Your knee hits the dashboard, and it basically pushes the hip out of the back of pushes the ball of the hip out of the socket at the back. And when you watch the replays on this injury, essentially a similar sort of thing happened to Tua, in that when he fell on the ground, his knee hit the turf with the two other players on top of him, creating that high energy force to basically generate the hip basically getting pushed out the back of the socket. Now, while the hip dislocated, because it happened so traumatically, it actually fractured a portion of the posterior wall or the back wall. So, I want the listeners to think of this more as a dislocation than as a fracture, but obviously it's a fracture dislocation because not only did it dislocate, but it also brought a portion of the socket was cracked as a result of it. And so there are a couple concerns with these injuries. One is that because it's so rare, when the injury occurs, that there could be also injury to the blood supply to the femoral head. And so if the blood supply is compromised, there's a high risk of what we call avascular necrosis, where essentially if, just like in any part of the body, if you cut off the blood supply, that area that the blood is going to can then die. Now, one of the most significant risk factors for AVN is the time in which the hip is reduced. Now, thankfully, the medical staff was phenomenal, and they reduced this, I believe, in the training room. I mean,
yeah,
they did it very quickly.
I'm not sure about that. I've heard mixed sort of information on it, but let's talk about that for a second. These kinds of injuries. Shoulder dislocation is one thing, but what's your sense? We do have X-ray available, but you oftentimes know exactly what happened. But one would think that they'd get a quick fluoroscan or an X-ray to show what happened, and then we would try to pull it and put it back into place. And you get a guy who's very muscular. Have you? I've never had to reduce a hip closed with the fracture dislocation. Have you done it?
Not a native hip, just an artificial hip.
Yeah, so it's really got to be tough. Like I had one interesting. I was a visiting professor at the University of Pittsburgh, and they were practicing, and I don't want to tell you how it happened, but it wasn't during practice, and one of the guys dislocated his knee. And we didn't, so what we often do is we try to get that relocated, and we pulled, and we could not. Some of these guys are so muscular, we just could not get it reduced, and we had to get them to the emergency room for sedation. So I would imagine it's technically, and the pain would make it very difficult to get the hip back into place. But what do we know about the time factor? I know it's critical because that's when the blood supply is probably threatened, when it's sitting out of the socket. Also, the nerves get compressed and so forth, so the risk goes up, I imagine, proportional to the amount of time it's out. Is there, I don't know if you'll even know the answer is there any data that tells us about how the length of time has a net effect on the downstream consequences of a dislocation like this?
Yes, I mean, the golden hour is thought to be within 6. So within 6 hours, the risk of AVN is about 5%. If greater than 6, the risk of AVN can be as high as 25%.
Yeah, so I think we could safely say that this was probably put in well before 6 hours. So is that the downstream effect? They say it's about a 5% incidence of avascular necrosis?
Correct.
Okay.
Correct. And if he develops that, then he would sustain essentially the similar prognosis as Bo Jackson did.
Right, it's a Bo Jackson hip. But then the other thing is that if he were to get it, and it doesn't sound like there's a high probability. So that's when the blood supply, let's just clarify, Steve. So that avascular necrosis, that's what Bo Jackson had. That's when the blood supply to the head of the hip is compromised and it essentially dies. But it dies over time. It's a series of stages where it will collapse over time. So, Shane, I imagine that if it did happen, it would be a slow thing that would develop years down the road. Is that fair to say?
Yes, although in some cases it could happen, I think in the short term, and in other cases it could be 5-10 years down the line. So it's always kind of looming in the background as far as is this a possibility. But if they did reduce it as soon as it's been reported, then that worst case scenario goes down to 5%.
Got it. So what's the treatment? Why don't we go over? So I just want to let everyone know who we're talking to. We're speaking with my partner Shane Nho, who's the director of our Hip Preservation Center. So Shane is a sports medicine specialist like myself, but he has a very unique area of expertise. And Shane, I'm not going to make you blush, but I mean, I would have to say you are clearly one of the top 2 or 3 hip specialists for non-hip replacement, but the sports or the athlete's hip. So you are my go-to for any athlete I see who has a hip problem, and these are typically younger patients who don't need a hip replacement but have a very significant injury like a labral tear and things of that nature. So I'm glad we have you on the show this morning because you're the only person I trust to ask some of these questions because none of us want to sensationalize it. This is a tough injury. We really want the facts. What was done most likely to repair this?
So let's. I think there's in terms of treatment, there's obviously short-term issues and long-term. And so the short-term, obviously immediate dislocation. Oftentimes they'll get a CT scan to make sure that there's no remaining either fragments within the joint that might necessitate more immediate concerns. But as far as what we can tell, once it's reduced and the fracture is sort of the only issue going on. Then in most cases, actually a traumatologist who specializes in pelvic and acetabular fractures is the person that would fix it. And essentially, they would do an open approach, and they would take the fragment. Now, we don't really have many details as far as the size of the fragments and how many fragments and so forth. Hopefully it's a pretty decent size, because the bigger it is, the better fixation you can get to it. It's no different than a bony Bankart. I mean, you've got some where you've got big pieces, and there are other ones where it's just kibbles and bits. And as long as it's a substantial piece, usually the bone has a good capacity to heal itself.
Got it.
Good stuff. Dr. Nho, we are out of time. By the way, Dr. Shane Nho, you can find him on Instagram at Chicago Hip Doc, D-O-C, and website, Shane, S-H-A-N-E. The last name is spelled N-H-O, and then it's MD.com, so ShaneNhoMD.com. You're the best, Dr. Nho. I appreciate it, and thanks for joining us here on this Saturday morning, Sports Medicine Weekly.
Thanks, Steve. Thanks, Brian. Thanks for having me.
All righty. We got to take a break. When we come back, it's our Ask the Doctor segment, where you get a chance to ask the doctor a segment. We'll tell you how you can get involved, and I've got some great questions this week for Dr. Cole. So stay with us. It's Sports Medicine Weekly, only on
670, The Score.